my poor souls here, y'all. There's only 4 people here.
It's okay, I can drive.
Okay, Mike can drive. All right, Mike, you're up. We're gonna finish the last 4 salivary cases, then move on to a couple other frozens.
Well, at a real just 1x, it looks like a relatively well circumscribed patient.
64-year-old female.
It's a lot prettier on the screen than the microscope.
Yeah.
So our normal salivary right here. Then there's our lesion. I would say it's relatively well circumscribed. It's actually a very good frozen section. Almost looks like perfect, doesn't it?
Yeah. Well cut.
Wish I knew who cut it because I'm confident. That person is clearly better than me at putting frozen. Yeah.
You wish there was a little microchip on everything that we touch, so like you just know we touched everything. That'd be creepy.
Well, that would make me very shameful if someone frozen it. This somewhat basaloid tumor. It's nests of cells. At this power, cells look pretty uniform, doesn't look high grade. So we have these multiple nests, many nests of tumor cells that are very small, prismatic, like uniform, no nucleoli, very bland cytologically. Same story here. We have these like kind of pink amorphous material inside these nets as well. Almost reminds me of collagenous spherolysis in breast.
Interesting, yeah.
Or like that can be also seen in prostate. Well, if anyone's interested in prostate, which is not.
What's it called in prostate?
It's called like microscopic collagenous nodules.
Microscopic collagenous nodules.
So it can be seen in the cribriform cancer, and apparently it's very specific calling. It's not seen in benign structures.
Cool.
Usually, you know it's cancer already because it's cribriform.
So you just slide it.
Yeah.
Okay.
So I don't see any necrosis. I haven't seen any obvious body figure or increase in it. I personally don't know what it is. So if I got this as my frozen, I would probably call it as a low grade salivary neoplasm, deferred to permanent. If you show it to Dr. Cipriani to save me.
That seems reasonable.
But I like to further.
Yeah.
Just trying to see whether there's anything that something more of this than what I think it is.
Right.
These like benign dots, and then there are these next to it. So it kind of almost makes me think that these cells are kind of occupying the dots, especially when I see these basement membrane material. Also reminds me of some site too. think this is like true invasion or getting out of the capsule because I just think we're cutting in a wrong plane. Like here too, I thought for a second whether it's like an invasion or something, breaking out of encapsulation or capsule. But it doesn't have any reaction to it. The cause curve is the same.
You always see plastic reaction. with
Nope.
Salivary invasion. No.
No, we don't. It's a treat. Well, that's as far as I can go.
Okay,
this
so
time,
yeah, I think for frozen low grade, I mean, salivary neoplasm is completely okay. Usually these very blue tumors end up like on FNA, just being kind of diagnosed as basaloid salivary neoplasm. And it's these that often at the time of frozen, some kind of differential diagnosis can be helpful if you can provide it. So generally these basaloid neoplasms end up being like cellular PAs, adenoid cystic, basal cell neoplasms. So just sort of to keep in mind what that differential is generally on from FNA, that's called quote unquote basaloid. So I can later I'll tell you what this is called, but does anybody have any specific diagnoses they want to throw out other than low grade?
Wondering about basal cell.
All right, so we have a basal cell adenoma, we have I heard adenoid cystic. Okay. Okay, adenoid cystic, okay. Minor. Check the periphery, what's this? I don't think it's minor. Submandibular, depending on what's back there. That's it. Oh, yeah, huh?
Yeah.
So tell me about membranous pattern.
So I thought of membranous because this has its basement membrane like material which is surrounding each of these nodules or lobules. But adenoid cystic is also one of the differential because it's kind of not fully well circumscribed, but in the periphery, it's actually like spreading.
Yep,
Like some invading edge with shrink edge.
yep.
So my two differential is one is adenoid cystic carcinoma and basal cell adenoma membranous type.
Okay. Is there a malignant counterpart to basal cell adenoma? Basal cell adenocarcinoma, so could that be a possibility? So the quote unquote membranous pattern is slightly different than that tubular-trabecular pattern that we saw the other day. And this quote unquote membranous pattern, it's a little more of that jigsaw puzzle-y kind of interconnected pieces with basement membrane material, eosinophilic as described by Anushmita, kind of wrapping around the nests and dividing these jigsaw puzzle pieces. So because these are basaloid or basal type of cells, those collagenous spherulosis type of, can you find those in here? So those eosinophilic, quote unquote, why do I keep saying quotes today? Those eosinophilic globules are also very, yeah, they're in there, are also very characteristic of basal cell neoplasms. whether they be basal cell adenomas or adenocarcinomas. Yep. So unlike the cribriform spaces in adenoid cystic, which tend to have bluish, like connective tissue mucin, the spaces here are filled by this eosinophilic dense basement membrane material, which is the same as those outlining the nests, right? So those are subtle differences between adenoid cystic and basal cell neoplasms, all right? So the membranous pattern with basement membrane material combined with it was raised whether this represents kind of in situ neoplasia in the ducts versus peripheral infiltration. Do you guys have votes on where we most likely are here? Is this infiltrative or not?
So this field I was very worried.
Yeah.
Because I see entrapped normal salivary that's done.
Yeah.
And this is destroying and getting out.
Yeah.
So just based on this area, I don't think I can call this
Yeah.
It's not inside too, because
Right.
it's destroyed. This was probably all normal salivary and then just placed and destroyed it instead of growing in slowly.
Do it.
Was pressing on it. This area is just slammed down to me.
Yeah.
Sign of malignancy.
Yeah.
This should not be, and there was like fat too, so this probably is just
Yep.
destruction.
Yep, for sure. So, okay, so in infiltrative carcinoma, that I think shows more features similar to basal cell neoplasm than adenoid cystic, so basal cell adenocarcinoma. But the features of high grade processes aren't here, right? Let me show you the stains. So here's P4. So, for me, P40 and c-KIT are the things, right?
Right.
So it'll show you the myoepithelial cells and the epithelial cells.
So this is P40.
Thing with basal cell and adenoid cystic, right, and pleomorphic adenoma, which we talked about last time, they're all biphasic. So you should expect them all to have some
Yep.
positivity for P40, especially in the peripheral kind of abluminal population.
You can see there are luminal cells inside that are not staining. It's kind of highlighted periphery
Yep.
of each nest, which is nice.
And the myoepithelial cells are the ones that tend to secrete the basement membrane material, right? So those are generally at the outside. Then here's c-KIT for the epithelial cell population, which, honestly isn't quite as beautifully crisp, right, as in adenoid cystic. But it still shows some cells.
This one's a good one in this.
Yeah,
This one. Clean the luminal cells.
Right.
here.
right. We talked about beta-catenin in basal cell adenoma, right? We saw the nice beta-catenin in the basal cell adenoma. So here's the basal cell, here's the
Wow.
beta-catenin here.
I'm not even. But
But you have to go to high power because you have to see if it's in the nucleus or not. Yeah, it's membranous.
it's probably
So it's not, right? So beta-catenin pretty much, look here, look at the normal salivary next door. It's for fun, look at that,
yeah.
right? I mean, that normally beta-catenin is like that on the membrane. So it's like that on the membrane of the tumor. And unless it's relocalized to the nucleus, you can't consider it as being significant,
You can actually see the nuclei not staining in
Yeah.
many of these cells.
right?
It's sparing it.
Right. So like we talked about, basal cell adenocarcinomas don't really have beta-catenin mutations. They have the CYLD, the cylindroma gene mutations. We didn't do sequencing, I don't think, on this case, so I don't know. But it's certainly not positive, right? So if it were positive, you'd have to think more about a benign adenoma. But all of the features we've already described favor malignancy here. Yeah.
Okay.
So so do we know if the next dissection was done on this person? Is that,
Oh, after the fact?
no, during the surgery? 'Cause that's the So this was called adenoid cystic carcinoma on Frozen. And revised be basal cell adenocarcinoma. So the one question that I don't have answered here, but I'm gonna look up real quick is if this person underwent neck dissection, because usually when we call something adenoid cystic, that might buy them a neck dissection. If you were to call something a basal cell or a low grade, whatever, not adenoid cystic, they may not have gotten a neck dissection. So I'm just gonna pull this guy's chart up real quick to see if they got a neck dissection or not. This 2020, all right. Report. Yep, right neck levels 1 through 4, sparing internal jugular. So, fine needle at here. Patient is a 64-year-old, right submandibular gland, fine needle aspiration demonstrated basaloid neoplasm. Consensus was to proceed with submandibular resection and possible neck dissection. And then Frozen section revealed adenoid cystic with solid architecture. Given the high-risk features, we proceeded with neck dissection. And fact, Western, no, I don't want Northwestern. I don't remember if his no's were positive, do you? They were all negative. It's too bad. It doesn't go as far back as I needed to. Anyway, so this person may have been bought a neck dissection that they may not have needed. We can follow up on whether there were any positive notes. I don't think there were, but usually that's what will happen, right, when you call something adenoid cystic. So, you know, unfortunate in this case, but you know, the morphologic features can be overlapping between these two types of things. And I think there are subtle differences that can distinguish them.
Would there be like, there's no stain to this basal side, of course, no.
So some people use MIC, immunostain, which is supposed to be positive in adenoid cystic. MIB, because of the MIB NFIB translocation. We don't have that stain. And based on my reading in the literature, it's not highly specific.
Okay.
So you can have MIB expression in non-adenoid cystic carcinomas, and I don't know how robustly positive it is in 100% of adenoid cystics, right? So I don't think it's, for me, it's not sensitive or specific enough to say, yes, MIB is positive, therefore it's adenoid cystic. And at the time of Frozen, you're not gonna be able to do that anyway, right?
Right.
Like, so I don't know. You could, if you guys find anything better in the literature about MIB, let me know, but I haven't found it to be that useful. Just like there's also a PLAG immunostain for pleomorphic adenoma gene, but it's like also positive in some tumors that don't have PLAG gene rearrangement. So I'm like, it's those kind of things that I don't find really helpful. So.
So to you, this does not look like adenoid cystic, right?
No.
Like, so,
No.
okay. Cause like when I
doesn't.
was looking at a Frozen, I was like, that's in a differential, but I
Oh,
don't
yeah.
wanna call it because I know it's gonna grant.
Right.
But then,
Right.
my other question is, if this had beta-catenin staining that was more like
Nuclear.
nuclear in some areas, but based on this infiltration pattern, would you feel comfortable calling it basal cell adenoma? Or would
No,
you-
no,
right?
no,
So
no,
that
no.
won't tip
I-
you towards the
no.
other side.
No,
Okay.
no, I think it's infiltrative and
Gotcha.
therefore I would still call it
Call it that,
carcinoma
okay.
regardless what the stain is.
Yeah, okay, so it's the pattern, the morphology that trumps
Yeah.
everything else. We are just using the c-kit and the P40 to prove that it's biphasic.
Mhm.
And that's- Okay,
Yep,
So why was this thing?
what stain?
debated?
Fun, I don't know, to see. Because I don't think the genomics of basal cell adenoma and adenocarcinoma aren't like so fully fleshed out as like adenoid cystic or pleomorphic adenoma. Like these are rarer tumors. So like, yeah, one group said that they haven't found beta catenin mutations in an adenocarcinoma, but that doesn't mean it doesn't exist, right? Like, so I think it's kind of, kind of for curiosity and interest, if nothing else. Like I wouldn't have changed my diagnosis with it if it being positive, but it's sort of more of an interest educational type of thing. Yeah. And on that note, we talked about LEF1 last time, saying that LEF1 has been shown to be positive in the nucleus of the basal cell neoplasms. And yep, it is here as well, but like, again, I don't find it to be very specific. I'm sort of doing the LEF1s as education because like, I've been finding that they're positive in more things, and so I don't trust it, right? It's kind of like my own learning. Do you have a question, Greta?
Can these metastasize to liver?
The
We have a
liver?
liver lesion that looks very similar.
Sure, why not?
Existing, but
Uh-huh.
it actually has like this steps. So yeah.
Anything is possible. Usually they tend to be low grade, but then again, they're very, very rare. So with salivary, you can have high grade variants of everything, right? That can go to liver. And so sure. Is it recent?
Yeah, Allison will probably come.
Oh,
show
I'd
you.
love to see it. Like, yay.
Most interesting.
No, that's tumor.
That's tumor. It's pretty far.
Yeah, see, you can see it. That's one good thing
Yeah.
about it. You can highlight the infiltration.
Yeah. That's crazy. I also saw it.
Yeah.
Cool.
All right,
Thank you.
good stuff.
Okay, it's-
Yeah, we don't get many, I mean, this is a rare tumor, so it's nice to see. Case 9. Go for it.
Yeah. Sorry, let me just check the chat before I start.
Thank you.
No problem.
Of course not. This is a 68-year-old male with a history of pancreatic neuroendocrine tumor, all right. CT neck soft tissue, showed infiltrative left submandibular tumor, measured up to 45 millimeters, so 4.5 centimeters.
It's from submandibular lesion.
Submandibular.
So far I see a fully biopsy. It looks like something malignant. Cytoplasm. Basaloid and the infiltrate. There is a doctor. I don't see any. I think it's something basaloid and. So
Yeah, right, very dark, very infiltrative, very nested, possible PNI. So at least we can say malignant, right? Well, at least we can say malignant, and I think you are suggesting that it could very well be adenoid cystic. With this amount of like kind of small nested infiltration and dark wrinkly kind of nuclei, I think adenoid cystic is a really good option. So I think it should be at least raised, if not outright, not necessarily, it doesn't have to be outright called, but certainly highly infiltrative, very dark neoplasm or, carcinoma, fine.
And there's
So-
a tumor where in the liver? In the primary,
No, that was her. There's tumor in the submandibular and there's also cervical lymph node, cervical lymphadenopathy. So presumably based on the clinical picture, right, this is presumably already metastatic, the cervical lymphadenopathy. But they have no diagnosis apparently. So they're sending you a core biopsy at the time of frozen. And they want you to call it malignant, which hopefully I think we all agree we can do. Okay, go back up to that net, see how the holes right in the center of the nest are more bluish?
Yeah.
Rather than that densely eosinophilic globule that we saw in the basal cell, right? So this kind of stuff is much more bluish mucin than the basement membrane material. And it doesn't have the rind, right, of basement membrane either. So there are a few clues here that are already suggesting that this could be adenoid cystic. That's just the permanently frozen. And so then they sent another frozen. Gland.
has this, retinoid cystic imagine. Spaces and it's quite infiltrated.
So remember in the parotid and submandibular regions, there are intra and periglandular nodes that can be involved by direct extension of tumor rather than by true lymphatic metastasis, right? So one has to always keep in mind, not that it necessarily matters for frozen if they're sending you a chunk of tissue and it's got, gland and node in it, but especially on your synoptic reporting and on your permanent sections, if you have your primary tumor that's intraglandular and it is directly infiltrating from the main tumor mass into an adjacent node, we prefer to regard that as direct invasion of a lymph node and not stage it as a positive node because it hasn't gotten there by lymphatic spread. It's gotten there by direct route, right? That's different from if the node is separate, right? And you see it separate, then you can call it, you can assume that it got there via traveling, but not if it's like right next door and it's just blow through, right? Set different topic, but yes, so I think this is pretty good for that. Let me give you another couple sections.
And it has different prognosis, like direct extension versus.
Yeah, it's different. It wouldn't be considered an end. If that was all the node that was involved, it wouldn't necessarily be considered an end stage and they wouldn't regard it as having already kind of left the box, right?
When you're the same tumor is going to be muscle. and
Yeah,
It's very bad.
it's bad. So, look at the neural invasion. Yeah. So, this is what adenoid cystic does and why it's really, really hard to fully excise and why the prognosis for adenoid cystic in general, regardless of low grade, high grade, whatever, is worse because number one, it sticks up to the nerves and it travels locally and it invades backwards, like up to the skull base, right? So you have a lot of local recurrence because of that. It tends to have higher rates of lymphatic invasion or angio invasion, and so it spreads to lung, liver, bone, etc. Right? So these are really nasty tumors. Really nasty. I don't think I have stains here for this one. But the tubular, so the tubular adenoid cystic and the cribiform adenoid cystic are both patterns that are commonly seen as here, right? So you have tubular where it's just kind of a bilayered tubule, right? You have cribiform where it looks like a Swiss cheese, and you have solid, right? You just get sort of these solid sheets or nests or insular islands. So many PNIs.
It's retinoid carcinoma.
Yeah. I think that's submandibular region. I mean, I don't know if you can separate. They probably had to take out, you know, digastric and mass. They probably had it. It's probably, yeah.
What was the diagnosis?
So actually, well, I don't know. I don't know if it was A or B that was called adenoid cystic, but I know at least B was called adenoid cystic on Frozen. I don't know what A was called. But I'm not sure I would have been able to call adenoid cystic fully on A, on the first one, the core. I certainly would have been able to call it malignant, but I think B is much clearer, yeah. Jen, no, we okay?
Did you turn off the screen that off?
You're too
Sorry,
good.
no,
You're
no.
too good. It's like,
Yeah, I know.
it's like,
It just scared me.
it's
Every tech issue
people
just.
leave the microscope for
drives me
hours
crazy.
and don't turn it off. So thank you. All right, next.
I was like, oh no.
Fifty-one-year-old female parotid.
Where it looks like. This is just. Rotted gland with. Lymphocytes forming. Large aggregates that are. But that parotid doesn't really look quite normal. But this is. Have these large. This is only.
If you were to regard this as normal parotid, what's missing? think those are planned. I'm just asking, I don't know. Kind of please myself.
Well, they look glandular. They look like they're. Yeah, I don't, okay, I take back what I said. I don't think that this is normal parotid. I think this is probably all one large mass with no normal. I don't see any normal parotid here. But I don't know. It's kind of almost forming like these globules separated by these large intervening fibrous bands and very large aggregates of lymphocytes. And the cells are, neoplastic cells are kind of wanting to form these glands. They don't look like great glandular architecture, but they look like they're trying to form glands. The nuclei are overall, they have kind of a bubbly appearance to them. The nuclei are pretty low grade. I don't see any mitotic. I don't really see mitotic activity. No, I don't know if there was necrosis in that top piece.
There's no, you just flew by normal gland, by the way.
Okay. Yeah. So overall, I would say a low grade neoplasm on frozen.
Awesome, no, that's exactly, so it was called low-grade neoplasm, favor something, I won't tell you what yet. But it doesn't really matter what was favored as long as you agree that it's a low-grade neoplasm, which I do. It's interesting that you said that your initial gut reaction was that this was just parotid. And I think I might know why you said that, which is kind of a hint as to the diagnosis. So normal parotid is composed entirely of what kind of cell? Serous or mucinous? Serous, okay. Mucinous cells can form little acini too, right? So, all right, so entirely serous acinar cells. So when you thought this was parotid, I thought that was really telling of the more cytomorphology of these things, which very closely perhaps resembles, right? Serous acinar cells.
So
Associated inflammation, right?
yeah.
And not good ductal lobular architecture, right? So when I said what's missing, sort of you're missing the ducts and you're missing that ductal lobular architecture. And the cells that are creating a neoplasm have more of they're almost like a cribriform kind of pattern, right?
Looks locally though. It looks like it's perhaps locally a little bit destructive in architecture.
Yeah.
So at this point, I'm kind of more worried that it's perhaps. So maybe
So that. And I think you mean a cynic. But what kind of cells are you looking for in a cynic? Yeah. So go on high power on some of those cells. We talked about this last time, but what do you want to see in the cytoplasm of the cells that lets you know that they are differentiating towards acinar cells? Serous acinar cells, I should say. mostly blood. Although there are a few cells at the bottom of it. It. Zymogen granules, right? So you want to see the dense purple, dark purple zymogen. So go on one higher power and flip the condenser. Right, so you see the super dark kind of granular cytoplasm. And so, yeah, so acidic cell carcinoma. So, I mean, these cells here, they pretty much look exactly like your background acini, but you know, based on your low power architecture that you're in a mat, you're in a tumor, right? You're in a tumor. So acidic cell carcinomas can have this microcystic kind of cribiform growth pattern, and often a ton of associated lymphoid inflammation, right? So both of those features are not uncommon for this type of tumor, but there's no benign counterpart to this, right? There's no acidic cell adenoma, right? So once you see these sheets of serous acinar cells, you're basically already at a low grade acidic cell. Okay, and I agree the high grade figures here are not present. Questions? I don't think we have a
How
PA
to
side.
distinguish acidic cell carcinoma from the lymphoepithelial carcinoma?
Ah, okay. So in its heart and soul, what is lymphoepithelial carcinoma? What are the epithelial cells of a lymphoepithelial carcinoma?
That should be like a keratin positive, right?
Not only keratin, but I mean these are keratin positive, but what are they? Are they serous? Are they mucinous? Are they something else? Squamous. They're squamous, exactly. So quote unquote lymphoepithelial carcinoma is essentially a squamous cell carcinoma with lymphoid stroma in any part of the body that you throw it in. And so you would have expression of high molecular weight keratin of P63, P40, and a non-keratinizing squamoid morphology. Whereas in here, these are serous acinar cells, so they're P40, P63 negative and high molecular weight keratin negative. They should have PAS positive diastase resistant granules. And lymphoepithelial carcinoma generally would be more squamoid morphology, squamoid immunoprofile, usually higher grade, because usually squamous cell morphology carcinomas should show some mitoses, nuclear pleomorphism, et cetera. And so when you have a quote unquote lymphoepithelial carcinoma, God, I need to stop doing these quotes, lymphoepithelial carcinoma of the salivary gland, you have to ask yourself, what do you want to ask yourself?
Those epithelial cells are squamous cells or like salivary glands.
Right. So right. So if you prove that they are squamous cells, then what do you ask yourself? Where's it coming from? So you can have non-keratinizing squamous cell carcinomas with lymphoid stroma, which is basically a lymphoepithelial carcinoma. It's a non-keratinizing squamous cell carcinoma with lymphoid stroma. Is it coming from the nasopharynx? Is it EBV? Is it coming from the oropharynx? Is it HPV? And so you have to prove those stains, investigate those areas clinically, and then if all is said and done, then you could consider a primary if there's nothing anywhere else. But primary lymphoepithelial carcinomas have been described. They have been associated with EBV, but my question is, do they really represent primaries in the parotid or are they occult metastases? You know, I don't know that that's ever really been documented because it's been reported that they're primary, but I don't know what that really means. HPV, pretty much no. Like if they're HPV, they're generally considered to be metastases. If they're EBV, people will report occasional EBV positive primaries in the parotid, but again, I'm not sure if I 100% believe that. So you have to be highly suspicious that it's a metastasis if it has a virus in it. Yeah.
Yeah.
already did this one. And then last one. Right neck mass. In the parotid area. 57 years old.
You're so
It is difficult to distinguish whether this is a mass arising in the inferior portion of the parotid or in the upper neck abutting the parotid. He has refused FNA. Are there any questions in the Zoom?
Oh, yeah.
Can you give me the history again, sorry?
57-year-old woman.
Previous one, the question was mucin is that the question.
Mm,
We cleared that.
yeah, so I don't think there was truly mucin in there. I think that was just pale zymogen granules and microcystic spaces. And you can prove the zymogen granules with PAS diastase, which are gonna be nice and gritty. 7-year-old longstanding right neck mass. She's worried, but she refuses FNA, so she'll go for surgery, but she won't go for FNA, fine. It's challenging to distinguish clinically, right, whether this is a lower tail of parotid mass or upper neck abutting parotid, so somewhere back here.
Pink material here. I can't tell if some of this is like necrotic. Fibrinous or. Here. This like collagenous stroma with these cells like, that are in, well, I don't know, I'm not gonna say infiltrating them, but that are there. And. Tissue or something. I'm gonna tell whether they're like. That's right here. Investigating. I don't know, guys, I'm having a hard time finding like tumor. Cultural plus or something.
It is a mass. Yes, those are cholesterol clefts. Yes, those are probably residual salivary ducts at the periphery, right?
Other inflammatory cells. Would scan it on Zoom for Dr. Cipriani to be like, hey, I don't think there's anything like going on here.
You are at a hospital in
Right.
small town America, and Dr. Cipriani is in Italy. You're gonna tell.
There's Zoom in Italy.
Zoom in Italy.
Okay, so I'm just gonna say like a negative. I'm gonna say negative for carcinoma.
Okay, all right.
I think it's just like inflammatory tissue. I don't know how much I have to say.
Yeah,
on the
that's
thing,
what
so.
you have to say. That's what you have to say. I agree. There's not a single neoplastic cell that I can find in this whole field. It's kind of grungy, kind of nasty. All right, so how about a permanent or permanent sections? I don't know which is better. I've heard both.
More cholesterol plus. Granulated giant cells. The other cells. Vessels, carotid, well. Or I don't know, these look like the money shot cells maybe. This side though, like again, if they're just foamy histiocytes or if they're actually tumor cells now. There's like two cell types going on here because it's giving me like this mucinous vibe maybe. But I can't see like an epithelial component.
Yeah, I mean, vacuolated cytoplasm is pretty good for histiocyte, right?
Yeah. I mean, I don't. Right now, there's like a xanthoma thing going on, but I can't like figure out
Why?
like what's causing
Yep.
this.
Here, let me see if I can find, so yeah, so you're doing, yeah, I don't know, I like here, let me try. You're right, there's nothing here, right? This is all, it's all foamy histiocytes and cholesterol. So then you have to ask yourself, why, like, why, right? Why? So what could some options be? What? Infective, okay. Foreign,
Hypercholesterolemia.
hypercholest, well, why is it mass forming in the parotid and then you have this normal, right? It's like, it's not like diffuse and it's not involving other vessels, all right? Yeah, I mean, I think this could be a number of things. I don't know if we have the, okay, there is some epithelial lining.
You like epidermal inclusion cyst or something.
So, yeah, we don't really get epidermal inclusion cysts in the parotid. We get a few things. We can get lymphoepithelial cysts or branchial cleft type of cysts. Right, so no, that's a good question. You have to ask yourself, is there any, are there any mucinous cells, and could it be a cystic mucoep,
Yeah,
right, like we saw earlier? Are there any oncocytic cells? Could it be a Warthin? These are very, very good possibilities. Is it just squamous? Is this, if it is just squamous, is the squamous metaplastic, right? All these questions. I don't know that we have answers to. Anybody think it's, first of all, does anyone think it's malignant? I guess is the important question. Like, unless you can find mucin in here and you want to call it a mucoep, I think we can't really have any evidence for cystic malignancy otherwise. Tumor to undergo this kind of change. Does anybody know? This is high end, high level.
Some sort of a hematoma or
What?
hematoma.
Hematoma?
There's something like a,
Teratoma?
Salivary, that can be those.
Yeah, what salivary lesion commonly undergoes xanthal granulomatous change like this? Yeah, so it is Warthin. It is Warthin. So I don't know what this cystic epithelium here is doing, if this is metaplastic squamous. I don't see anything that looks overtly like Warthin. Like, I don't see the perfect structures. However, based on retrospective review, it has been documented that most times that you see this foamy histiocyte and the xanthogranulomatous reaction, it is often in the context of a Warthin tumor, either based on prior FNA or based on finding a little corner of Warthin tumor somewhere in the person's periphery here. I don't know if it's because of all these cytoplasmic debris or the mitic, right? Think about Warthin tumors are full of oncocytes, which are full of mitochondria, which are full of cell membranes, which are full of cholesterol. So maybe it makes sense why you get this cholesterol clefting and this xanthogranulomatous relaxation, because you just like exploded membrane out into the world. But the report here says that they saw a tiny bit of Warthin tumor. Now, I don't know if it's on these slides. I definitely see cyst, but I don't see Warthin tumor. So maybe we don't have that slide. But the person's report did say that they saw a little tiny residual Warthin
They
tumor.
say focally ghosted out tissue
Yeah,
shows features suggestive
of Warthin. Yeah, fine. So I mean, you don't necessarily have to come down on that diagnosis if you don't see Warthin, but just know that you should be looking for that, right? Submit more, like try and find it, because then you can say, all right, this is not something else, right? This isn't some weird infectious disease, or this isn't some cancer that necrosed. It's just a nasty, probably Warthin.
Do you mention it during process?
You mentioned what?
What is that it could be a word then? Like if we didn't have any component of it.
Oh, yeah, I think it could be discussed with the surgeon. Yeah, I mean, I think you could say, hey, all I see is xanthogranulomatous, blah. Most commonly, this ends up being Warthin, but I will have to submit the rest. Or whatever, something like that. So yeah, I think that's reasonable to say. All right, it's 9:03. I guess we'll stop. Unless anybody wants to do a sinus nasal one. We can save that for next time. Since we're done with the salivary, so. We're done. Okay, so then the question is, our next, well, do you guys have any questions so far?
Can I do
We're going to scan them and then give them to you as